All right, if you're a pathology trainee, you totally know that feeling. You've got a big cancer resection staring back at you from the grossing bench. It can be, well, a little intimidating, right? So today, we're going to tackle one of the most critical tools you have, the CAP protocol, and we're zeroing in on larynx cancer. Let's dive in and demystify this thing together. So here's the game plan. We'll start with why this standard is so important, then get into the nitty-gritty of anatomy and specimen handling. We'll look at tumor type and grade, talk about margins and local invasion, then tackle nodal staging and this critical finding called ENE. And to wrap it up, we'll put all the pieces together to build that final TNM stage. Think of this as a virtual sign-out from start to finish. Okay, so first up, the standard for larynx cancers. Why is this protocol such a big deal? I mean, it's easy to just see it as, another form you have to fill out to keep the accreditors happy. But trust me, it is so much more than that. And hey, don't just take my word for it. The protocol itself basically says that it's the foundation of practical info that benefits everyone involved. Every single box you check, every measurement you take, it all builds this standardized, super high-quality report. And that report, it becomes the absolute bedrock for everything that happens next. We're talking treatment planning, prognosis. It directly impacts the patient's entire journey. Section 2, Anatomy and Specimen Handling. Okay, let's get our hands dirty, so to speak. Picture this. A fresh larynx specimen has just landed on your grossing bench. Now, before you even think about grabbing a blade, the number one most crucial first step is orientation. And to do that, you've got to know the anatomy like the back of your hand. So check this out. The larynx is basically broken down into three main zones. You've got the supraglottis up top, the glottis right in the middle, that's where the vocal cords live, and then the subglottis down below. Your first job is to pinpoint exactly where that tumor is centered. Why? Because the staging rules are totally different for each of these spots. It's a critical first step. But this is where things get tricky, and honestly, where a great pathologist really shines. We have to go hunting in the deep spaces. Think of these as secret tunnels or back alleys for the tumor to sneak through, completely silent and invisible to the surgeon or the radiologist. Okay, so here are the two big ones you have to know. On the left, that's the paraglottic space, nestled right next to the vocal cords. On the right, the pre-epiglottic space. They're just full of fat and soft tissue, which is like a super highway for cancer cells. And here's the kicker, the reason this matters so much. Finding tumor in either of these spaces can instantly upstage a tumor from a PT2 to a PT3. That's not a small change. That is a massive jump that completely alters the entire treatment plan. Section 3, tumor type and grade. All right, specimens grossed, sections are cut. Let's head over to the scope. Now we get to find out what exactly we're looking at on a cellular level. Now look, the vast majority of the time, we're talking over 90%, it's going to be a squamous cell carcinoma. It's the usual suspect. But, and this is a big but, you can't get complacent. The larynx has other stuff in it, right? Minor salivary glands, neuroendocrine cells, which means a whole different menu of tumors can show up. And you better believe each one of those has its own set of rules we have to follow. Now, let's talk grade. This is a measure of how aggressive the tumor looks. And what's really interesting here is that it's not a one-size-fits-all deal. For your standard squamous cell carcinoma, yeah, we use the classic system. Well, moderately, poorly differentiated. You know the drill. But here's a super important point. For any of those salivary gland type tumors, the protocol is crystal clear. We do not use a generic grading system anymore. So what do we do instead? We stratify them by risk. This table simplifies it, but you'll get the idea. The diagnosis itself is the grade. So if you call something a salivary duct carcinoma, bam, that automatically puts it in the high aggression bucket. It's way more specific and way more helpful to the oncologist than just slapping a generic grade 3 on it. Section 4, margins and local invasion. Okay, moving on. Now for the million-dollar question. The one every surgeon is waiting to hear the answer to. Are the margins clear? And getting this right is just absolutely critical. A positive margin is simple. Tumor is touching the ink. That means cancer was likely left behind, and the patient probably needs more treatment. But for a close margin, just saying it's close isn't good enough. You have to get out your micrometer and report the exact distance, right down to the millimeter. Why? Because that number tells the radiation oncologist exactly how wide they need to set their radiation field.
And we're not just looking at the edges of the specimen, we're also hunting for other sneaky types of invasion. We're talking lymphatic and vascular invasion, or LVI, and perineural invasion, PNI. That's when tumor cells are in vessels or wrapping around nerves. Both are bad news for sure, but PNI is a really big deal. In fact, it's a required element in the report. Think about it. Tumors use nerves like their own personal highway system to spread, and finding PNI is a huge red flag for the cancer coming back later on.
All right, section 5, nodal staging and ENE. Let's shift gears from the primary tumor and look at the neck dissection that usually comes with it. The story the lymph nodes tell us is absolutely central to staging the patient correctly. So, when that neck dissection hits your bench, it should be marked by the surgeon into different levels. Our job is to figure out which of those levels has cancer in it. This isn't just some academic exercise. This information is basically a map for the radiation oncologist, showing them exactly where to aim their beams. Okay, so you find a positive node. Great. Well, not great for the patient, but good job finding it. Now comes what is arguably the single most important question you will answer. Is there extranodal extension? We call it ENE. This is where the cancer has literally busted through the wall of the lymph node and is spilling out into the surrounding fat. And finding it, well, it's a huge flashing red light for that patient's prognosis.
And it's so important, in fact, that the latest staging system, the AJCC 8th edition, made a massive change. Now, the presence or absence of ENE can, all by itself, change the patient's end stage, single-handedly. Just look at this table. It shows you exactly what a game changer this is. In the old days, a single 2-centimeter positive node was a PN1. Simple. But now, that exact same node, same size, same spot, gets upstaged to a PN2A just because ENE is present. That one microscopic finding completely changes the stage. That's how powerful this is. And finally, section 6, synthesizing the TNM stage. All right, we're on the home stretch. We've collected all this data on the tumor, the nodes, the margins. Now we have to synthesize it into the final pathologic stage. So the T for tumor stage, a lot of that depends on where we said the tumor started, way back at the gross bench. But here's a really important thing to remember. For tumors in the glottis or supraglottis, the stage also depends on clinical info, like whether the vocal cords were moving or not. It's a fantastic reminder that we don't work in a vacuum, right? We have to combine our findings with what the surgeon saw to get the stage right. So you just have to be methodical. Step 1, figure out the final PT using the site, size, and all those invasion patterns we talked about. Step 2, determine the PN based on the number of nodes, their size, which side they're on, and of course, that all-important ENE status. And step 3, you combine PT, PN, and M for metastasis, and boom, you have your final pathologic stage group. So when you boil it all down, what's the big takeaway here? It's that your report is so much more than just a document. It is literally the roadmap for treatment. Every single one of those data points, from the tumor's location to that millimeter measurement at the margin to whether or not you found ENE, every single one directly shapes the decisions about radiation, chemo, and how that patient will be followed for the rest of their life. Think of it this way. Every checkbox you fill in on that protocol is you answering a critical question about that patient's future. The CAP protocol gives you the structure, the questions, but it's your expertise, your sharp eye at the scope that provides the answers. It's a massive responsibility for sure, but when you master this, you're ready for it. So the only question is, are you ready to answer?